Hello friends, today we are going to discuss about Generalized Anxiety Disorder, also called as GAD. This is the part 2 of the video. To see part 1, visit my YouTube channel. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at NIMANS, Bangalore. In this video, I'll be discussing about the burden of GAD, the GAD presenting in primary healthcare center, how to improve the diagnosis, neurobiology of generalized anxiety disorder, treatment, course and outcome. Understanding the concept of GAD. Although generalized anxiety disorder has been introduced in 1980, but it has gone various changes. It has evolved over a period of time. But one need to understand the concept of GAD. The classical features of generalized anxiety disorder is, first and the foremost, is free-floating anxiety. That means this anxiety is not particularly to any specific condition, such as social phobia, OCD, or any specific medical condition or psychiatric condition. That is the first one. Second one is uncontrolled worry about the day-to-day events. These worry will also with regard to negative outcome of day-to-day events. And this worry should not be in one or two areas. It should be more than 2 or 3 areas where we can say, yes, this person has persistent, uncontrolled worries about the day-to-day events. And this worry should be at least for 6 months. Along with this, the patient should have at least 3 symptoms: being on the edge, having startle reflex, easy fatigability, impaired attention and concentration, increased muscle tension, irritability, and insomnia. If you look at the epidemiology of generalized anxiety disorder, it is the very commonest disorder in the general public. The lifetime prevalence is around 6%. And also, if you look at the 1-year prevalence of generalized anxiety disorder, it is around 3%. GAD is considered as one of the most common anxiety disorder presenting in primary healthcare center. Not only that, it is the second commonest diagnosis which is seen in primary healthcare center. Of course, the first one is depression. Let's understand what is the burden of generalized anxiety disorder. Without knowing the burden, why should we know about GAD? Because generalized anxiety disorder is going to cause severe burden in a person with generalized anxiety disorder. There are 2 types of burden have been attributed and also measured. First and the foremost is human burden. The human burden is quantified. That means they quantify the impairment in role functioning and quality of life. There are 2 important things has been measured in human burden. That is impairment in role functioning and quality of life. Whereas economic burden, here the cost related to healthcare resource utilization and loss of work. That means here the burden with regard to economic is with regard to healthcare resource utilization, going to the hospital, travel, meeting the physician, consultation charges, medication charges, along with the loss of work. Both will be added to economic burden. There was an important study which did the review of human and economic burden published in Depression and Anxiety in 2008. This study is a meta-analysis of 34 studies looking at the burden of GAD. And this study clearly said that despite the differences in methodology and various study across the world, they clearly indicated GAD was uniquely associated with substantial human burden and economic burden. Further, by using statistical method, they controlled for various comorbidities such as depression, personality disorder, OCD. After controlling to comorbidities, GAD continues to be statistically significant with regard to human burden and economic burden. That means just because GAD has comorbidity, the burden doesn't increase. GAD as an independent diagnosis increases the burden, not only with comorbidity. Economic burden, if you look at that, 35 to 40% of the people with GAD had moderate to severe occupational role impairment. How much this impairment? That means every month, up to 6 to 7 days, they missed the work. That means they remained absent from work. Imagine, out of 1 month, if a person is unable to go for 1 week for work, that means 30% disability can be easily attributed. That means over a period of 1 year, you can say one third loss of productivity, coupled with help seeking behavior and also the loss of work burden. So if the national GDP, the GAD, if it is present, one third of the national GDP will be wasted. That means it has a high economic burden with regard to generalized anxiety disorder. Further, generalized anxiety disorder is associated with suicidal ideation. How many times? Sixfold when compared to general population. At the same time, the likelihood of attempt for suicide is 2 times than the general population. That means GAD has a high risk with regard to suicidal ideation and attempted suicide. Further, there was a one landmark study which looked into the 4-year prospective longitudinal community study of 22,548 adolescent and young adults. That means the children and the young adults between the age of 14 to 24 years. And they did a prospective study with regard to GAD. And they found that odds of developing depression in GAD is 4 to 5 times more than the general population. That means if you are seeing a GAD patient, there is a high risk he may develop depression in the near future. That means GAD is a high risk for developing depression. Further, there are many studies which clearly indicated GAD is associated with many medical conditions such as pain disorder, gastrointestinal disorder, cardiovascular disorder, endocrinal disorder, and respiratory condition. In one of the important WHO study from 14 countries from the primary care, in which 1 month prevalence of GAD was 7.9%. That is based on the ICD-10 criteria. That means if you look at the primary care studies, and 1 month prevalence is 8%. For every 100 patients who visit PHC, 8 of them have generalized anxiety disorder. Let's look GAD in the primary healthcare centers. GAD patients invariably present to the primary care doctors because of especially the nature of the illness, because of the constant worry or apprehensive which is persistently present. Hence, they go to the nearest doctor, that is primary care physician. Hence, if you look at the occurrence, it is the second most common psychiatric diagnosis in the primary healthcare settings. GAD is diagnosed up to 8% of the patient visiting the PHC. That means we have to look for GAD in PHCs. But you have to also understand GAD patients consult primary care doctors or physicians 5 times more than the general population. But they present with non-specific somatic symptoms. Many of our patients, especially in developing countries, they may not be able to verbalize the anxiety, such as, I'm having increased heartbeat, I'm worried, I'm anxious. They will not speak about that. Their distress is presented in the form of somatic complaints, such as chest pain, fatigue, generalized weakness. So that kind of symptoms will be presented. Not only that, difficulty in sleep, and also invariably tremors. So these are the presentation will be seen. But unfortunately, the diagnosis of GAD is made in 1/3 of the patient only. The studies have clearly indicated only 30% of the physician rightly diagnosed GAD. That means 2/3 of the patient, that is around 60 to 70% of the patient visiting PHCs never got the diagnosis of GAD, although they had GAD, resulting in wrong diagnosis, wrong treatment, delay in treatment, along with adding burden for buying those medication, visiting to the hospital for a wrong treatment adds to the economic burden. Now, how to improve the diagnosis of GAD in PHC? With regard to this, an international consensus group on depression produced a consensus statement that was published. They recommended 2 important screening questions to be asked by PHC doctors in every patient. That is, the PHC doctors should ask every patient visiting PHC these 2 questions. They are, during past 1 month, have you been bothered by feeling worried, tensed, anxious most of the time? So, very simple question. In the past month, are you worried? Are you anxious most of the time? Second question is, are you frequently tensed, irritable, and difficulty in sleeping? So, these are the two questions to be asked. Whenever they say yes, then you need to ask for GAD. Let's understand the neurobiology of generalized anxiety disorder. GAD has been conceptualized as a diagnosis which functions as a means to regulate affective discomfort. That means emotional dysregulation. In neuroanatomically, this generalized anxiety will be start from the amygdala. Further, the GAD also been attributed to the neurotransmitter imbalance such as serotonin, adrenaline, noradrenaline, catecholamines, steroids, and so forth. Further, abnormal HPA axis, hypothalamo-pituitary axis, has also been implicated because the stress response is mediated through hypothalamo-pituitary axis. That is, stress diathesis model has also been implicated. Further, the recent studies with regard to microbiota. The studies recently, they have even done the meta-analysis. And one of an important study which said that altered gut microbiome composition, that means lowered microbiota diversity, that is dysbiosis of gut microbiota, that means the diversity of the microbes in the gut, if it is less, there is high possibility the patient will suffer from GAD, and hence this dysbiosis has been considered as a pathogenesis for GAD. The reason being, gastrointestinal system is considered as a second brain because majority of the neurotransmitters are also produced here. Further, GAD also has been implicated as a multifactorial in origin. The pathogenesis of GAD involves complex interaction between genes and environment, that is epigenetic phenomena. Various studies have implicated the pathophysiology of GAD with regard to various brain abnormalities such as frontolimbic neural circuit, immune dysregulation, neurotransmitter dysregulation, and also neuroreceptor abnormalities, starting with gamma aminobutyric acid, HTP, serotonin, neurotropic factors, and also immune mediated cytokinins have also been considered. But however, genetic studies also been underpinning. Meta-analysis of family and twin studies reported that family members of patients with GAD were 6 times more likely to have GAD. That means, look at the numbers. 6 times. If one of the family member has GAD, the other person having GAD. Twin studies. The study which looked into the 63 monozygotic twins and 81 dizygotic twins, the concordance rate was 21% in monozygotic twins and 13% in dizygotic twins, indicating that genetics play a role in GAD. Further, there is an excellent review with regard to genetics of GAD. Please go through this excellent article looked into the genetics of generalized anxiety disorder. Summarizing this study clearly said that in candidate gene studies, partly combined with imaging and physiological readouts, the converging evidence clearly indicates some of the GAD susceptible genes with regard to serotonergic and catecholaminergic system, as well as BDNF gene has been implicated. Potential role of serotonergic candidate genes such as 5-HTTT and 5-HT2A, as well as COMT and CHR1 genes have been implicated. Further, gene environment studies have also been considered. They have highlighted the importance of early developmental trauma, recent stressful life events in interaction with molecular plasticity markers and their combined relevance to GAD. Trait anxiety and anxiety sensitivity and various gene has been implicated. That means if there is early childhood adversity is seen, that means there is various genes have been expressed. GAD is a heritable condition with the moderate genetic risk. Approximately 30% is the heritable risk. That means the genetic risk is 30%, and of course, environment also plays a role. Hence, the childhood adversity plays a very important role. Let's look at the various neuroimaging studies. There was an important meta-analysis was done. That is, in Brazilian Journal of Psychiatry, 2019, it was published. They included 89 studies with regard to structural and functional neuroimaging studies in GAD, a systematic review. So they considered 63 activation study, 26 structural studies, 20 MRI, 5 DTI study, and 1 DWI study was considered. And if you look at this image, you will be able to understand the studies summary. First and the foremost, there is increased gray matter volume and hyperactivation in amygdala. Further, anterior cingulate cortex. Again, there is a increased gray matter and hyperactivation. Further, post-central gyrus have been implicated. Further, you can also see the gray matter volume and also hypoactivation is reduced in dorsolateral prefrontal cortex and also in the ventrolateral prefrontal cortex. So, the areas which have been implicated with regard to neuroimaging studies in GAD are ventrolateral and dorsolateral prefrontal cortex, anterior cingulate, posterior parietal region, and amygdala. Both in pediatric and adult GAD studies, this has been found. To summarize the neurobiology, this is one of the easiest way to understand. If you look at the severity of the anxiety and also presence of comorbidity has been placed in a format of step ladder. If you look at the x-axis, you'll be able to see the age. As the age increases, that is the way you can understand. And the genetic loading as the earlier the onset. That means there is a high propensity of genetic interplay. And if you look at the early childhood, internalizing symptoms and inhibition is there. Further, neurobiological and cognitive behavioral changes and sensitization. Increasing sensitization, avoidance, and developmental change can be considered. Further, persistent cognitive behavioral changes. So, here the interaction between the genetics, environment, childhood adversities, the perception of an event, and various other factors play a role in the development of GAD. Further, in the initial part, there will be the formation of subclinical anxiety symptoms, panic attacks, circumscribed phobia can be there. But however, separation anxiety, childhood anxiety disorders are commonly seen. That is how it starts. Further, comorbid complex anxiety disorder patterns will be seen, such as OCD, or else anxious avoidant personality disorder, dependent personality disorder, OCPD can be seen. 2. Because of these various things, the person will start doing self-medication by using substances. And finally, you may also see anxiety disorder, comorbid with depression. That is the way the lifetime development of GAD and various other comorbid conditions could be understood. Let's understand about the treatment of generalized anxiety disorder. So when we plan the treatment, you need to do a good history taking. The good history taking plays a crucial role to rule out other comorbid psychiatric diagnosis. Please look for depression, personality disorder, other anxiety disorder like panic disorder, phobia, somatization, BDD, even other psychotic disorder. Along with this, please do a thorough general physical examination to look into any other medical conditions which are triggering as an anxiety disorder. Please do lab investigation, hemogram, biochem with regard to LFT, RFT, thyroid functions, electrolytes, and if you are suspecting any medical conditions, ECG, echo, MRI scan, especially the GAD if there is an adult onset. Now let's understand the first line of treatment. The first line of treatment in GAD, the first line of treatment is dictated by the presence of comorbidity. Because out of 10, 9 patients will have comorbid diagnosis. Is it depression? Is it OCPD? Is it OCD? Is it medical condition? That will dictate the choice of medication. The first commonest medication chosen is SSRI, selective serotonin reuptake inhibitors, such as sertraline 100 mg, escitalopram 20 mg, paroxetine 50 to 100 mg can be given. Serotonin norepinephrine reuptake inhibitors, SNRIs, such as venlafaxine 150 to 225 mg, desvenlafaxine up to 100 mg, duloxetine up to 60 mg. So, SSRI or the SNRI can be considered as the first line of treatment. The second line of pharmacotherapy is based upon if the patient's anxiety symptoms is very severe, disabling, and the anxiety symptoms need to be controlled very fast, then benzodiazepine can be chosen, such as long-acting diazepam, clonazepam can be considered. Other medication anxiolytics such as buspirone up to 60 mg, pregabalin 300 to 600 mg, opipramol up to 300 mg, and many a time antipsychotics such as quetiapine has also been considered. However, to prevent the relapse of GAD, it has been suggested that pharmacotherapy should be given at least for 6 months to 1 year. That means GAD requires at least 6 to 12 months of medication. But however, in case of children, pregnant women, geriatric disorder, or else other medical condition, in such a scenario, you may have to choose psychosocial management. That may be cognitive behavioral therapy, can be considered alone, or else pharmacotherapy alone, or combination of both can be considered. However, if you look at the NICE guideline, they consider psychotherapy as the first line of treatment with regard to GAD. But however, one need to understand there are two important factors which indicates medication is the best choice. The first one is the presence of comorbidity such as depression, personality disorder, medical condition will dictate we may have to consider medication, or else non-availability of the clinical psychologist or psychotherapist also play a crucial role. Hence, I would choose medication first or the combination of medication and therapy. Although the antidepressant are the cornerstay of pharmacological treatment in GAD, only 50 to 60% of the patient respond. But however, 30 to 50% of the patient reach remission only. That means GAD is a chronic condition. Hence, combining the various treatment strategy play a crucial role in GAD. However, recently the research is also looking at the non-invasive brain stimulation research. There is one of the important review published in 2019 in Progress in Neuropsychopharmacology and Biological Psychiatry. The title of the study is Non-Invasive Brain Stimulation in Generalized Anxiety Disorder, a systematic review. When this review was done in 2019, they were able to identify only 4 transcranial magnetic stimulation and 1 TDCS study. So the preliminary results from these non-invasive brain stimulation studies, they clearly indicated dorsolateral prefrontal cortex, except in one of the study, along with the parietal cortex, has been considered and stimulated. And the early results clearly indicates that non-invasive brain stimulation do decrease the anxiety symptoms, and improvements and follow-up studies are hardly for 3 months to 6 months. Hence, in the short term, NIBs can play a role in anxiety. But however, we need to follow up this patient and see how long the treatment continues to be effective. Now, let's look into the GAD and psychotherapy. There is one of an important study, a meta-analysis was published in Cognitive Behavioral Therapy Journal in 2020. Here, the meta-analysis clearly indicated there are various types of psychotherapy has been considered. There are huge number of RCTs with regard to CBT. But however, the metacognitive therapy, acceptance and commitment therapy, mindful-based techniques, and various other therapies have been considered. Although this study indicates that psychotherapy plays a crucial role in GAD, but however, They clearly said that the placebo arm or else randomized control trial has been clearly considered the waiting list, which plays a very low role or the drawback with considered to RCTs. Hence, head-to-head comparison between psychosocial treatment or psychotherapy with pharmacotherapy is difficult. But however, combining pharmacotherapy and psychotherapy plays a crucial role. Further, there are studies with regard to yoga, meditation, and relaxation also play a role in GAD. Other treatment modalities such as exercise, physical activity, counseling, psychoeducation about anxiety, anxiety disorder, online self therapy, anxiety confronting exercises in real life situation, use of self help manuals also play a role. But recently, I has mentioned, which talked about gut microbiota. That means you need to understand there are some food may provoke anxiety. That means the food and nutrition also play a role. At this point of time, we do not have a strong evidence. But having a good lifestyle and healthy food play a role in management of GAD. Let's understand the course and outcome of generalized anxiety disorder. GAD is a long-term illness. There is a high chance of recurrence. GAD persisted for longer than 5 years in 40% of the individuals. During the 12-year study, the average amount of the time the patient spent in GAD is 74%. That means the patient spent in illness was almost 9 to 10 years. Further, Harvard Brown Anxiety Research Program, which clearly found in GAD after 2 years, 60% of the GAD subjects continue to have active symptoms, and at 5 years, 66% of the patient continued to have symptoms. That means they had only partial remission or no remission at all. Hence, it is easy to conclude GAD is known for its chronicity, waxing and waning course. Only 1/3 of the patient have a complete remission. And because of the high level of comorbidity, presence of personality disorder, medical disorders, all of these play a role in chronicity. What are the predictors of poor outcome? First and the foremost is family stressors, poor relationship with the spouse, parents, presence of comorbid axis 1 disorder like depression, panic disorder, agoraphobia, substance dependence, alcohol dependence, female gender, presence of personality disorder, presence of comorbid medical conditions play an important role in chronicity. What are the predictors of non-responder? Worse treatment adherence, the person who does not take treatment. High risk of relapse is seen in them. Greater risk of other psychiatric and non-psychiatric illness. Further, all these increases the healthcare utilization by twice compared to the treatment responder. That means one need to understand if a person does not take treatment regularly, if there is multiple relapses, further comorbid condition is present, there is a high chances will be non-responder for the treatment. To conclude, my dear friends, GAD is very prevalent in primary care settings. The prevalence is around 8%. GAD is more than just a tendency to worry and should not be ignored at all. You cannot just say a person, don't worry. Many a time GAD can trigger the physical illness. Consider GAD when patient presents with unexplained somatic complaints. Explain, explore, and see whether the person is suffering from GAD. GAD is associated with substantial distress and disability. GAD is often associated with other medical condition and comorbid psychiatric disorders. Antidepressants such as sertraline are the first line of medical management. Psychotherapy and other psychosocial treatment are also considered to be effective. Of course, diet also play a role. GAD increases the chance of major depression, suicidal ideation, suicidal attempt. Hence, preventive approach should be taken in managing GAD. That means whenever you diagnose a GAD, be aggressive in treatment. If you don't treat GAD, there is high possibility the patient may also develop depression or else chronic medical condition. Hence, the individualized treatment on the basis of severity, anxiety arousal, somatization, comorbidity, and the acceptability of the patient with regard to treatment play a very crucial role in GAD. My dear friends, don't take generalized anxiety disorder very lightly. Understand about GAD, discuss the treatment management, chronicity of illness, and explore for comorbidities. That is GAD, my dear friends. Thank you very much for your valuable time. Stay safe.